Recording. Now we are recording. Okay. So let's just go through this list really quickly and let me talk about what we have here. So we have the three basic kinds of portal hypertension. Pre-sinusoidal, which usually means main portal vein thrombosis. Sinusoidal, meaning the liver itself. That's usually we're meaning cirrhosis. And then post-sinusoidal is usually Budd-Chiari. Budd-Chiari, if you remember, is the thrombosis of either the IVC or the hepatic veins or both. So heading on down with thrombosis of the main portal vein, pre-sinusoidal, no cirrhosis necessary, no liver disease at all even necessary. You got thrombosis of the main portal vein. And if it happens slowly over time, it really gives your body a chance to develop collaterals. If it happens acutely, you're definitely going to be in the emergency room. But the hepatic artery becomes the sole provider of blood into the liver, assuming we're talking about a full thrombosis, an occlusive thrombosis of the main portal vein. And the hepatic artery goes from 25% of the supply to the liver to 100% of the supply to the liver. That is until the collaterals form. And so collaterals will form. In this case, it is called cavernous transformation of the portal vein. In grayscale imaging, just to remind you, the main portal vein can be invisible as the thrombus can be isoechoic to liver. And in fact, let me add something right here. This is sometimes called hepatization. I think that's how you would spell it. It's kind of a made-up word anyway, so I'll spell it how I want. Hepatization of the main portal vein would mean that it basically looks like the liver, and that very well could happen. Or not, or it could be the thrombus is anechoic and you clearly see the main portal vein. But in either case, if we're talking about thrombosis, there will not be flow in the main portal vein. With cavernous transformation, you have collaterals forming to feed the liver through the kind of the pseudo portal system at that point. Okay, so that's one kind of portal hypertension. That will cause an increase in size of the portals or the splenic or the vein, the superior mesenteric vein. Those can increase in size with cavernous transformation because the blood flow is not as easy as it should be, if there is blood flow at all. Okay, let me move on. With cirrhosis, the liver tissue can't handle the volume of blood flow. And this is sinusoidal. There are many possible outcomes. Varices develop, and I drew in varices over here. The varices, the worst varices and the most common actually are the esophageal because of their tendency to bleed. Blood, and that's the worst varices. Of course, there's splenorenal varices, and there's hemorrhoidal varices, and there's all sorts of abdominal varices. Blood flow can be backwards, and I was kind of just writing this freehand down here. I totally forgot to mention this word yesterday. I was just suddenly, I'm going through this. I'm like, oh my God, I don't think I ever said hepatofugal. Hepatofugal is flow away from the liver, hepatofugal. So Main portal vein could run hepatofugally until a shunt is found back to the central venous system. So perhaps that shunt, perhaps a reversed flow can go down the main portal vein, all the way down the splenic vein until it finds a shunt, a little vein that happened to go from the splenic vein all the way down to the kidney, the renal vein, and then that becomes a shunt. It enlarges and becomes a shunt and gets blood back to the central venous system. The right portal vein could run backwards. If the right portal vein is backward, while the left portal vein is forward, this is an indication that the umbilical vein is acting as a shunt, taking blood, portal blood down to the umbilicus. So, and that kind of makes sense. So we would have hepatopedal forward flow in the main portal vein, forward flow in the left portal vein, but reversed in the right. And that's because all the blood, virtually all the blood, is actually being shunted away from the liver through the umbilical vein all the way down to the belly button. The caput medusae is a visual appearance of veins radiating out from the belly button. I already mentioned that. So in general, varices don't do the body any good, but the shunts do. The shunts are actually very helpful to the body. The blood has to go somewhere and the system needs to be decompressed. So that's what the shunts do. If the body hasn't compensated or compensated enough, doctors can help. Operations that basically connect the portal system to the IVC exist. And so that was the mesocaval shunt or the other operative shunts in the abdomen. However, people usually don't get that anymore. They get the TIPS procedure because that can be done, I think, practically on an outpatient basis. And it's probably one night stay, but I don't know for sure. But it's a very simple procedure compared to open surgery. Transesophageal, intrahepatic, portosystemic shunt. Far less invasive, far more common. I got a few pictures on this we'll talk about. Then we're going to talk about what I have over here, and then we're going to watch a video together, and I think that'll be it today. One last cause of portal hypertension, and Bud Chiari, or how about this? One last cause of portal hypertension, post-sinusoidal. So of the post-sinusoidals, Bud Chiari is pretty much by far the most common. I'm going to mention today also congestive heart failure. But that, anyway. Thrombosis of the hepatic veins or the IVC. If only one vein is thrombosed, the patient may be asymptomatic. I had a really interesting case where a gentleman came in and there, right on the edge of his rib cage, was something really hard, kind of sticking in. You go to push just under the rib cage, and you can clearly feel something quite hard. And so I went and started doing my scan, and sure enough, there was blood in the right. There was blood in the left, blood flow in the right and left. But I believe from my memory, it was the middle hepatic vein was thrombosed, actually similar to the picture right below here. It looks like the middle hepatic. And it ended up killing an entire segment of this gentleman's liver, and he never knew it. Never knew it. But if it was all three, he would know it. He would be he would be in the emergency room very quickly. If the IVC is thrombus of the liver, it's still Budd-Chiari. Okay, that's all I wrote. There's actually more I could write, and I will add to it from what we're going to talk about today. So here's clearly a picture of Budd-Chiari of the middle hepatic vein. You can see all this stuff in here is not good. And we have a nice clear view of the right hepatic vein. Great picture of a TIPS. You can see the actual, and by the way, they make this echogenic on purpose because they know that ultrasound is going to be the modality of choice to look at this. So there's no use in making this a very difficult to see device. You know, some devices they put in are actually very, very difficult for ultrasound to pick up. But this has the advantage of being echogenic, yet we see through it as well. So they've really designed this for ultrasound, well, as much as it's for the patient. But here, this looks like, I'm trying to think. Yeah, so I think I'm correct here. Just looking at this, we have a, obviously IVC here. That's the left, middle, and the right is unseen hepatic veins. So left, middle, and right. This is coming through the middle. And so what actually happened, the red arrow here shows the direction of blood flow. But what actually happened during delivery of this is that they started going up the middle, and the middle perhaps went off in this direction. The actual vein went off in this direction. And what they did is they started going up and they cut right through the side of the vein, through the parenchyma, and into the portal vein. This does appear to be left portal vein to me. That's possible. I'm incorrect, and that is a right portal vein, but it's like left to me. And so they've decompressed the portal system. Now this person is not going to develop any more varices, and more important, and most importantly, he's not going to develop varices such as esophageal that can bleed and actually have the patient bleed to death. Great picture of cavernous transformation. So you can see there's no identifiable main portal vein in here, and it's all these little bubbles of veins, and when you put color on, they're all filling in. So all of these are actually veins probably attached to the portal system, but they were at one point tiny and barely used veins. Now they have become important veins. That's cavernous transformation. Varices at the splenic hilum. This spleen is only slightly enlarged at 13.2 centimeters. It's pretty much, and they've measured, well, I probably would have put my caliper a little farther over, so maybe I've got 13.5. But in any case, that's a not very enlarged spleen, so just slight splenomegaly. But certainly all of these, and if you put color on this, these will all fill up, and that is not normal. Those are varicoceles. My pen does not work with that very well. Okay. And the last image I have for here right now is the caput medusae. So, you know, this was supposed to look like, it looks like this head's upside down, and then there's the hair is, they're like snakes all over the place. So it's like Medusa. And that, of course, is portal blood bypassing the liver, going through the umbilical vein, straight down to the umbilicus. Well, it can't go out of the umbilicus, and God, we hope not. So it stops right there. Well, it doesn't stop, but it just kind of says, well, I got to go somewhere. So now it's going to recruit. All of these veins were at one point tiny, insignificant veins. Now they're gigantic and significant. And here's an ultrasound image of the abdomen. So this person's probably has their transducer right about, God, that's a hairy, happy trail, isn't it? Ugh. Whoa. Don't want to drop your gum. Anyway, this transducer is probably right about here. A little bit, you know, it's right of center, and sagittal view. Here is all of this vein should not exist. There should be nothing here until about this point. This is the left portal vein. That should be there, but the rest of this should not be. Okay. So, like I said, so I have a great video for you guys to watch, and we're gonna, hopefully it's gonna go well for us to watch it together. That way I can stop and talk about some things as we're going through it. And the video actually does, it brings up some things that I quite frankly failed to speak about, and I'm kicking myself, so that's why we're doing this today. So let's just start with the portal vein here. So I really didn't talk about the waveform, because when we do this, let's get a good layer. When we do this, we're gonna get our, we're gonna put this is my spectral gate, and I'm gonna put my gate here, and your pulse wave, spectral, whatever you want to call it. The pulse wave is going to be right about here. And in this case, on color Doppler, you actually want your main portal vein red. Veins, I know, are normally blue. In this case, we want it to be red because it is actually feeding an organ. Very unusual for a vein. So we go ahead and leave it red. And we leave the waveform above the baseline. Now, some people don't care. I do, because I think there's a very important difference between this picture and this picture down here. So we leave above the baseline. Zoom up so we can see that writing a little bit better. So normal, all right? It's a pedipedal. Forward flow, and that's why I have it above the baseline. Slightly phasic meaning you take a breath, veins are phasic. But I added a little bump. It's okay to have a slight pulsatility. In other words, on top of the phasic, I kind of have one breath here, and then another breath is starting here. I also have heart rhythm, boom, 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 boom. So that is okay as long as it's slight. It could be absent, but you certainly don't want to see heavy heart pulsations here. That indicates a heart issue, if that is the case, if that's what you find. Now, here we have abnormal, assuming you've set up your Doppler correctly, and instead of on the color, instead of red, you have blue, and on your spectral, instead of above the baseline, it's below the baseline, and you double check to make sure that you didn't set it up backwards. You have a hepatofugal flow. The blood is flowing backwards down the portal vein. So that is in the case of severe cirrhosis, severe portal hypertension. And I drew down here, probably could have done a better job actually. You know, if you're seeing boom, 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 that's too much heart pulsations. And what that could actually indicate is not so much cirrhosis, because this is going in the correct direction. about the correct speed. It's not a terribly fast vein or vessel. Maybe 25 centimeters per second at the most, 20, 15, something like that. But if you see heart pulsations that are pretty significant, that could be an indication of congestive heart failure. Congestive heart failure. I'm going to put a question mark here because it's not always super clear what we're seeing, but that is a indication. Now, if you suspect congestive heart failure in the absence of all sorts of other things going on, you could actually look at the hepatic veins and see what they're doing. So let me go back to the hepatic veins. Oh, I want to talk about that too over there. But so right, middle, left hepatic veins. Remember, when we see them sorry, I was going. I'm going a little fast up until here due to the fact that I did think I was doing more of a review. But if you guys feel like I'm going too fast, then I'm going too fast. So, okay. All right. Well, the document that I was working on, the review document, I'm gonna build that out a little bit better and repost that. And that was mostly a review of what we spoke about yesterday. Portal veins here. Portal veins, you know, part of the problem, guys, is that you're not scanning. This is so hard to talk about when you're not scanning. So yeah, let's go over this again real quickly. A normal portal vein is hepatopedal, forward flow, slightly phasic. In other words, when you breathe, you can do that. It's maybe slightly, on top of being slightly phasic, it can be slightly pulsatile. As long as it's not overly pulsatile, that's okay. So that's hepatopedal forward flow in the portal vein. A totally abnormal would be reversal of flow. So this is hepatofugal. The flow is backwards in the portal vein, meaning the liver simply cannot handle the blood flow, and so it's going to send it. It's going to send it backwards down the portal vein. And you know what? I'll jump to this. That's what I'll do. Okay. I only mentioned congestive heart failure because it has a analog to this waveform of the hepatic veins. So these are my hepatic vein waveforms over here. Let me mention this guy over here again. So remember, now I have the portal vein over here, colored blue, and the hepatic artery, colored red. And our Doppler, they're both going to be red. They are both traveling up. So you have this arrow here and an arrow here, both traveling into the liver. They're both hepatopedal. They mix. Inside the hepatic lobule, they will actually mix, and there are connections back and forth here. In the case of when these hepatocytes can't handle this blood flow, and remember this portal vein is, let's draw it here, 75%, and the hepatic artery is normally 25% of the blood flow into the liver. This might be 25%, but the hepatic artery is under high pressure. It's under heart pressure. The portal vein is under low pressure. And so when these hepatocytes They say they can't handle the blood flow. They're not going to tell the hepatic artery they can't handle the blood flow. They're basically going to tell the portal vein. So the portal vein is now has to, cannot bring its blood freely up into the liver. So what ends up happening is you have all this excess blood coming up now under higher pressure through the artery. It's going to essentially come around and go back down the portal veins. So that's what's happening more on the microscopic level, is the hepatic artery is back feeding the portal vein. So now the portal vein runs backwards. Okay. So I mentioned, I talked a little bit about hepatic veins, and if we have a thrombosis here and a thrombosis there and a thrombosis there, that's really bad. That's all three hepatic veins, that kind of thrombosis, or if the thrombosis is here, blocking the blood flow into the right atrium of the heart. Remember, this is right up near the heart. That is Budd Chiari. That is Budd Chiari, when those vessels are blocked. Okay. Now, a normal waveform, and this is something similar. If you got when we were doing carotids, if you got the subclavian vein at the right point, it actually looked a lot like this. I don't think we really need to go into, well, I'll just mention that there's an S, D, and an A portion to this wave. We normally don't. As sonographers, we're not terribly concerned about naming these, but this is ventricular systole. No, not a Y. Systole, just an I. Anyway, ventricular systole. Oh, and by the way, hepatic veins go away from the liver, so their waveform should be, and pretty much always is, below the baseline. So the direction of flow is away from us, or away from the liver, I should say. So below the baseline, that's why we have it down here. It should, by the way, that looks like a W, 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 W. The S is ventricular systole, the D is ventricular diastole. So this is the pumping action of the heart. It looks like this, even though veins normally are a little more monophasic. Veins that are very close to the heart can be multiphasic because of their proximity. Multiphasic because of their proximity to the heart. And they actually speed up with systole of the ventricle on the right side. So this is the right ventricle that is moving this along. And instead of pushing it like an artery, you could say that the heart pushes blood through the arterial system. You could almost say that this is kind of sucking it through, because as the ventricle has systole, the blood flow is going to be drawn in, to the into the atrium. There's a little bit of a jag here in diastole. And then when the atrium itself contracts, and that's a much weaker contraction. Atrium's the only contraction or the only blood they move is from atrium into ventricles. So they're much weaker. The ventricles have far stronger contraction. So anyway, as the atrium contracts, the blood is pushed backwards in the hepatic vein. And then it relaxes and starts over again. So what that means, let's see, we're going to have our this is our pulse wave line. We'll put our little region of interest box here. And blood, for the most part, is traveling to the heart. And then it has a tiny little reversal, but majority of blood's traveling to the heart. And that's what we're seeing down here. The majority of blood is to the heart, tiny reversal at A, to the heart, tiny reversal at A.
Be careful you don't trip on Marcel's toys here.
Okay. Now I don't know that either book mentions this waveform. But this is an important waveform. It's not only a cirrhosis waveform, but I would say NASH as well. Anything that stiffens the liver takes away all of this multiphasic flow. So when we have a stiffened liver, and sometimes often a swollen liver, you don't get this nice multiphasic flow. You just get a monophasic flow. It's going in the right direction. This is away from the liver towards the heart, below the baseline. It's the correct direction, but it's very monophasic. And so with really fatty livers or definitely with cirrhosis, this is something we can see. It's not, you could call this up here. Windkessel, how about this? Windkessel-like, that way I'm keeping it. That's not really the Windkessel effect. The Windkessel is more of an arterial effect, but this is very similar. It is, a lot of this movement is from, the energy comes from the heart, but the pliability of the vessels allows this waveform to happen. Down here, there is no pliability. And not only that, the vessels are even squeezed together from the swollen hepatocytes. And so not only is the liver stiff, but these vessels are squeezed out. You end up getting monophasic flow with NASH, non-alcoholic, or alcoholic steatohepatitis or cirrhosis. And then the last waveform I want to mention is this one, where maybe I could have still had a little A and D wave there, but I've taken away the D wave. That's fine. So we just have an A wave. I'm sorry, S and D. S, and then if I had a little bump here, we call that the D. But that's okay. Because what I really just want to show you is that on this person, the A wave is significant. It's significant, and that's because it's congestive heart failure. When someone has congestive heart failure, the blood pressure in the right atrium goes way up. And so with higher blood pressure in the right atrium, that creates more of a backwards flow in the hepatic vein. So if you have an exaggerated waveform, in fact, here, let's draw, just use blue here. Let's draw this again, except anyway. So with the blue line, I've added the S and the D components, but then I still exaggerated the A. With an exaggeration of this waveform, it could be congestive heart failure. And the analog, all the way back through the liver, through the sinusoids, all the way back to the main portal vein, these two guys, if you find them together, then you really have a strong case to go to the doctor. Most people know they have congestive heart failure. It's kind of hard not to know. But if they don't know for some reason, you have a pretty strong case to go back to the doctor and say, look, doctor, I have an exaggerated waveform in the hepatic veins. I have a pulsatile, pulsatile wave. I have a pulsatile waveform in the main portal vein that suggests to me, doctor, that this person has congestive heart failure. Okay. 140. Good timing. All right. I'm sorry. I started out a little fast. I felt like I was. It's hard. I don't want to spend too much time in review if you don't need it, but if you need it, I'll spend all the time you guys need. So by all means, continue to let me know via text or group chat or whatever. Okay, we're going to take a break. When we come back, like I said, I have a great video. I really hope you could watch that. Oh, and I posted a lung video. So we don't. Healthy lungs we don't see. We get to the diaphragm, and then it's just, we have a very bright diaphragm to begin with, and then beyond the diaphragm it's air, and we don't see through air with ultrasound. But if the lungs start to fill with fluid, even just a tiny bit of fluid, there's changes that could be created in the reverberation pattern, which is kind of cool. And this is, and the entire idea of looking at lungs for ultrasound is fairly new. I mean, it's probably at least 10 years old, but still, it's fairly new. And now with COVID-19, there's actually an entire protocol that they've developed, pulmonologists have developed to look at to look at the lungs and really be able to establish how bad this person is. And the other way to look at lungs is X-ray, and quite frankly, X-ray is not that good. CTs are pretty decent. But in any case, the webinar is tomorrow. Starts at 10 Eastern time, and I was thinking, oh, geez, maybe I see if I can get everyone to get on there at 10. And as I read along, it became clear to me that it was actually available from 10 Eastern, 8 o'clock our time, until 8 o'clock our time the next day. So 24 hours it's available. I do want you to view that. As I went onto the site, I did have to, I'm already registered, but it'll make you register on the site. It is a free, but they try to get you to pay for things. So just make sure you're not paying for anything. And so when you get to the payment page, you've got like 5 items to remove. So make sure you remove all the paid items and only sit there for the free one. I'm paying $25 for CMEs, but I don't think CMEs are going to do you any good as students. I don't think. Anyway, so that's something tomorrow. You could sign up for it today and view it at any time tomorrow. It's an hour it's like an hour and a quarter, hour and 15 minutes. So we can consider that part of your class time, I think. Maybe. Anyhow, all right, 1:44. I'll see you guys back here at 2 o'clock.